Hello, welcome to Building Blocks, a telementoring series that's a part of Project First Line, CDC's National Training Collaborative for Infection Prevention and Control. In the AMA's work with Project First Line, we have heard from physicians that there are significant challenges in facilities outside the acute hospital setting. Places like acute rehab facilities, pediatric offices, and behavioral health centers, to name a few. To help meet these challenges, we developed this telementoring series, bringing in physicians from these settings with IPC experts from across the country. This section will focus on some IPC questions that can arise within ambulatory surgery centers. These facilities have inherent challenges. They are typically physically separate from an acute care hospital, and they have limited contact with infection preventionists. They often have independent owners separate from the local health system. Before I move on to today's case presentation and resulting discussion, I'd like to remind everyone that the opinions expressed in this session are those of the presenters only and do not necessarily reflect the official position of the American Medical Association, U.S. Department of Health and Human Services, the Centers for Disease Control and Prevention, or the presenters' affiliated institutions. We have some ground rules to cover. First, this is an all-share, all-learn format, so judging is not appropriate. It's okay to disagree, and those disagreements can lead to great discussion, as many of these cases highlight some gray areas of infection prevention. But we want to make sure our words and language remain respectful. For those of you joining in chat and asking questions, please introduce yourself and highlight the state you work in and your role in the healthcare system, physician, nurse, therapist, or other role. We want to tailor our answers to what's most helpful to you. And lastly, please do not put any PHI in the chat. Just keep questions general. Before we get started, let me introduce our panel. I'm Erica Kaufman-West, the Director of Infectious Diseases at the AMA. I'm the physician lead on Project First Line and continue to practice infectious diseases in Indiana. Our presenter today is Rebecca Batches. Rebecca is an infection prevention and control expert for Diversey. She earned a Bachelor of Arts degree in English and Spanish Literature from Wayne State University and a master's degree in public health from Benedictine University. Rebecca achieved board certification in infection control in 2019 and became a fellow in APIC in 2022. Our subject matter expert is Dr. Priya Nori. Dr. Nori is the medical director of antimicrobial stewardship at the Montefiore Health System in the Bronx, New York, the chair of the SHEA Stewardship Committee, and deputy editor of the SHEA Journal, Antimicrobial Stewardship and Healthcare Epidemiology. Today, we're going to look at one case in depth and cover how an infection preventionist can evaluate and investigate a possible outbreak at an ambulatory surgery center. Rebecca, can you first set the stage for us about what this surgery center looks like, and then we can get into how the situation came to your attention?
Absolutely. So we're talking about an outpatient surgery center that is affiliated with an acute care hospital. Interestingly, this is a smaller acute care hospital, 36 beds, and as you described, that it is physically separate from the main campus. And there are 2 active operating rooms in this smaller surgery center, approximately 15 or so surgeons primarily performing different procedures there. There are a lot of hand cases. That was the procedure that was most often occurring in this outpatient surgery center. And whenever intraoperative cultures were taken, it's important to note that this facility did not have its own microbiology department, and everything was sent out to various reference labs. And my role was as the infection preventionist. So I was responsible for any outpatient centers and, of course, the acute care hospital as well.
Great. So my understanding is that one of the surgeon's clinic managers called you with a concern that there had been 3 hand infections from that surgeon in the last 2 weeks. And all of those cultures were growing Staph aureus, some MRSA and some MSSA. And the clinic manager wasn't exactly sure what to do next. Does that ring a bell?
Yeah, actually, that's spot on. So it wasn't very common for me to get a lot of phone calls from the various surgeons' offices. I was somewhat new there, so was really trying to build relationships with clinical managers and the clinical staff which of course is challenging because the surgeon's offices are also separate from the acute care facility and typically in another location beyond the outpatient center. So it was the first red flag that somebody called me and let me know that there were several patients who had come in for rechecks, and all of them had very concerning signs and symptoms of infection at the surgical site. As mentioned, they were all Staph aureus. They were a combination of MRSA and MSSA, but it was the same surgeon, and it was the clinical manager working with that surgeon letting me know. So I had, and the same location. So some very powerful red flags for an infection preventionist where we have location, common surgeon, and of course, pathogen commonality. Those were things that triggered me to make sure I was acting quickly.
Dr. Nori, Rebecca mentioned some of the challenges with ambulatory surgery centers. Any other ones that you want to bring to mind here for our audience today?
Absolutely, Erica. And thank you, Rebecca, for setting the stage here. So I think that certain challenges have certainly been mentioned in terms of staff and having touch points among the staff. And clearly, many surgeons work in the center, and it may be difficult to understand their schedules and their workflows. But other challenges that I can think of have to do with what Rebecca mentioned before, which is that the physical connectivity between this standalone center and, let's say, the closest large hospital where there would be a well-staffed infection prevention program, hopefully a stewardship program, just kind of a central hub where protocols and best practices can be disseminated from. So these sites, while they're taking on lots of risk, they're providing a great service for the community. But with that, of course, comes the need to ensure that there is some central place for where they would have the resources to receive the oversight that they need when it comes to infection prevention and stewardship. So for instance, surgical prep, what is happening there in terms of standardization? Is it following recommended society guidelines for the Hand Surgery Society? Are they following APIC guidelines? Are the antibiotic prophylaxis recommendations up to speed? Are patients receiving that in a timely way? So there's the usual factors we look into in surgical site infections and, let's say, the acute care setting. Same things can be applied here, but they would be, of course, more challenging being a standalone center like this.
Yeah, and I think one thing that comes to mind just in talking about this case and other cases is, environmental services and the role of room turnover. That's always a concern, right, with surgeons, is making sure that rooms are turned over quickly, that there's no wasted time in those in between cases. And I'm sure, Rebecca, this facility also had some sort of cleaning protocol in place. Did they have a specific EVS contract during the day? Was it just at night, or how was room turnover handled there?
That's a great question, because I think it's something that we're not focused on enough in infection prevention and environmental hygiene. Like many other ambulatory surgical centers that I've been in, the clinical staff actually does the majority of the in-between case cleaning. And so they're balancing preparing for the next case on top of actually making sure that they have a safe environment. And of course, there's always that pressure for turnaround time and the surgeons waiting because they have many cases booked in a day. As I've learned more about environmental hygiene, I think of things like the appropriate disinfectants and how they're being utilized. Is the contact time being achieved? And then typically there's a whole separate team that would come in the evening. And like we're having healthcare staffing challenges everywhere, these contracted building service contractors and environmental services teams, they may not be employed by that ASC. And so we have to consider what type of training do they have? Do they have the skills for a proper operating room terminal clean? And are they using the products that have been selected by the ASC? That's a big question I always am asking myself. Or do they bring something that's been approved through the back door? So these are all really important questions when we think about the environment and how that's being handled.
Yeah, thanks. I think that as you start looking at the different moving parts of an ambulatory surgery center and how many different sort of people are contracted in, it really sort of magnifies where things could go wrong. Rebecca, can you walk us through your investigation? The clinic manager brings this to your attention. Your spidey senses are tingling. Something doesn't feel right. What's your next step here?
So the next step after I collected all of the patient names and started my classic infection prevention line list, got the details, verified all of the information. Importantly, I got the lab culture data sent to me so I could actually look at it and verify everything, the dates, collection sites, etc., which was very important because I otherwise would not have received that laboratory data in my position. There was no way to get all of the outpatient clinical cultures back to me. So once I verified all of those preliminary details, then I figured out when the surgeon would be in the operating room next. Typically in ASCs, surgeons have schedules that they adhere to, maybe performing cases on Mondays and Wednesdays, Tuesdays and Thursdays, et cetera. So you can anticipate when you might need to go meet with them. And so I figured out the day of the week that would be best. And that was really the most important for me, is to get there as soon as possible. In an outbreak scenario, we need to act very quickly. There's not time to take weeks to gather information. You really should go into the setting as soon as possible once you have that preliminary data. So the surgeon was great. I made sure the surgeon knew that I was coming so that nobody was surprised. I worked with the OR manager. The clinical staff was very welcoming. Everybody was aware that there had been several cases. And so for me, there was a culture of safety and accountability already present because everybody wanted to help to understand what was going on. So I stayed for most of the day so I could get a variety of different cases and watch the in-between case cleaning. I was primarily concerned with skin prep because these were hand cases. I know that we use our hands a lot. And so there are cracks and crevices. And I would imagine, even though I've never done skin prep myself, that it would be very challenging in a hand. And so that was something I was very, very much wanting to observe, is the skin prep of a hand. And I noted that the surgeon did a great job with hand hygiene, PPE donning and doffing, as did most of the other staff. There are always opportunities for improved hand hygiene in operating rooms. But what concerned me the most is that I found a multi-use gallon-sized jug of CHG, or chlorhexidine gluconate, that was being used across patients. And so this was very concerning to me, knowing that that jug had been in the room for many days, if not weeks and months. So they would use that until it ran out. They would pour that into a single-use emesis basin. And then the other thing that struck me was that after the CHG was applied to the hand, it was rinsed off. And for me, my spidey senses were also feeling like, I don't think they're supposed to be rinsing the CHG off. So those were some of the key things when I was thinking of the body part involved, the challenges with skin prep, and really looking at that multi-use container that was staying in the room for long periods.
Rebecca, did they give you a reason as to why they were washing off the chlorhexidine after applying it?
The reasons, if I recall, this was a while ago, was that the stickiness of the CHG made it difficult for the surgeon to do what he or she needed to do in that case. I should mention, it was sterile water. It was not tap water. I probably would have passed out if it was tap water, but that still made me think I need to go back before I intervene. I need to go back, look at the product, read the label, ensure that I had the correct understanding. Maybe there was a you must rinse step that I was not aware of. I certainly was never a surgical infection prevention expert where I felt 1,000% confidence walking into an operating room. In fact, I was very intimidated, and I have a lot to learn about surgery. So I was in a discovery phase. Before I said they had to change anything, I went back to the label. But what I heard when I questioned the practice was that without rinsing it, made it very more challenging for the surgeon to proceed.
Got it. Well, it sounds like you learned a lot from being in the OR and watching, and obviously from the welcoming atmosphere that the surgeon and the staff had, which is always great to hear. Dr. Norris, can you go into a little bit for us, because, reporting things and definitions are always a hot point when we have these discussions. Can you talk a little bit about what are these NHSN definitions when we talk about SSIs, and is there a role for using them or not using them if we have a type of SSI that's not a reportable SSI?
Right. So that is inherently the challenge here, is that this type of surgery is not necessarily one in the purview of NHSN when it comes to healthcare associated infections. And so for these, while the stakes are very high, of course, it's the hand, and that can lead to significant morbidity for the patient. In terms of regulatory purview, it may slip under the radar because a surgical site infection in this area may not be reported to NHSN per se. However, a small cluster like this in a short time may end up being flagged by other regulatory agencies. So, for instance, I could envision that the local health department potentially might get involved here. And that could be a good thing, actually, because number one, they are another set of eyes in terms of what could have gone wrong in the chain of events. The other thing is that public health laboratories frequently have these high-level diagnostic tests that they can do, such as sequencing, to see if there's any clonal relationship between the 3 Staph aureus cases. And also, they can potentially link that to a specific CHG preparation, a specific delivery method, or the outside of the bottle, or you name it. They may be helpful in their like typical disease detective kind of way. So just to circle back to your original question, Erica, yes, it is challenging when the surgery itself can slip under the radar, but be very serious nonetheless, because the hand is considered, like the face or the brain or other sites, a critical area for human functioning, and it should not be taken any less lightly for that reason.
Now, the next step, so Rebecca has done her sort of intraoperative, going to look at the labels, figure out how to help this team in their sort of case preparation going forward, and seeing if that will make a difference in their infection rates. From an ID perspective, so for infectious disease physicians, what role can we have in looking at antimicrobial stewardship, specifically when it relates to pre-op prophylaxis? So we have a lot of patients that come in with different allergies that are sort of flagged, and it takes time to go through those and really examine them and talk about them. But how important is it to discuss those penicillin allergies and to talk to patients about what this pre-op prophylaxis means?
Yes, absolutely. So thank you for bringing up all those really critical issues here. So there's a couple of things going through my mind, both as a steward and actually as an orthopedic ID specialist. The first one I'm thinking is, man, I hope that the surgeon has a good ID doc in the neighborhood that they're referring all these cases to, so that they can, provide the antibiotic management aspect of this. The other thing I was thinking about was, CHG is inherently anti-staphylococcal. So that adds kind of another layer of complexity here as to, what is actually the source of this? Is it the solution itself, or is it the practice of washing it off immediately? So the disease detective spidey sense, as you said, Erica, is really firing. But coming back to the very evidence-based practice of surgical site infection prevention through antibiotic prophylaxis, for something like this, we would typically give cefazolin, also known as Ancef, the surgeons like to call it, and that's pretty standard. But one thing that the areas where this may go off the rails a little bit is when the patient has an antibiotic allergy. Often those antibiotic allergies are really distant. They're from childhood. But nevertheless, if you don't take the time to ask just a series of simple questions like, how old were you at the time? What exactly happened? Was it a rash, or was it something where you had your airway at risk? With a series of very simple questions, the vast majority of these allergies can be debunked. And also skin testing or small amounts of exposure to allergen to see if a patient has a immediate hypersensitivity reaction actually is not needed to the extent that we used to think, because just from simple questions, most allergies can be debunked. And in fact, something like 90% of patients who reported antibiotic allergies to something like a beta-lactam, such as cefazolin or penicillin, those are frequently old allergies, and they can tolerate just fine the standard of care surgical antibiotics, which is usually cefazolin in a case like this. So it just requires a couple of steps and often can be built into the checklist aspect of infection prevention for surgical site infections. So reviewing the protocols as pertains to not only the prep, but the antibiotics involved can be extremely useful here. The other area as a steward that we see that maybe there's room for improvement among the surgeons or the anesthesiologists who are actually ordering and administering these medications is the dose. So while cefazolin is the right drug to give 9 times out of 10 for most surgeries, making sure that it's the right dose for the patient. So for instance, at our hospital, if a patient is 100 kilograms or more, we may even up the dose beyond the usual 2 grams, sometimes to 3 grams. If the patient is a little old lady who's 80 pounds, we may reduce that typical 2-gram dose to a 1-gram dose, especially if it's let's say this is Florida and there's an elderly population, they're on dialysis, you name it. You have to kind of customize it a little bit to the host at play. And so ensuring that those are also built into these protocols is going to be very important.
Yeah, I think having a good relationship with your pharmacist to be able to make sure that you have these protocols in place, make sure that the surgical team and the pre-op team is aware how important it is to go through these antibiotics. I've several times had patients where I said, it says you have a penicillin allergy, what happened? They said, well, my mom is allergic to penicillin, so they just told me to just say I'm allergic to penicillin too. But rarely are allergies sort of passed down that way. So oftentimes just in talking to people, you'll find out that it caused GI upset, or, there was some sort of other adverse reaction that really is an adverse reaction and not a true allergy. There's also this really great tool that we will link to in our resources section that's called PenFast, and you can also Google PenFast calculator. And it takes you through like 5 easy questions to ask people to get a good handle on what is the likelihood that the penicillin allergy is real. It sort of gives you a percentage, and whether you can go on. A lot of penicillin allergies can be removed just by using the PenFast tool. The other important thing to remember is that cefazolin, which, as Dr. Norrie said, is one of our more common surgical prophylaxis antibiotics, is that it has a different R side chain than penicillin has. And so the chance of cross reaction, even with a true penicillin allergy that maybe was a rash, is very low. So oftentimes you can proceed with cefazolin, or perhaps moving to the skin testing like Dr. Norrie suggested. But really taking the time to deal with those listed allergies can make a big impact in the patient's outcome, because we know that pre-op antibiotics really do play a big role in that. Rebecca, so back to our case here, I was hoping you could give us a little bit of an update as to how your conversations went when you went back, you read the bottle, you figured out that, maybe the multi-use bottle is not the best option for this. How did you have those discussions with the surgeon, and what was that interaction like?
Well, once I confirmed that rinsing was inappropriate and that a multi-use CHG container is not appropriate for preoperative skin prep, all of those have to be single use per the FDA. Then I worked directly with the OR manager, somebody that was really ingrained with the staff and the surgeons. So finding that central person who can really be that change agent. And as you two were talking, I was really thinking something important to bring up. The major player that we don't always have is the trusted infectious disease physician at our fingertips. A lot of these conversations and decisions I was doing independently. I did have access to a contracted infectious disease physician, but unfortunately that physician wasn't available to me all the time. In fact, maybe once monthly we met if I was lucky. So I really missed that relationship with an infectious disease physician that I had at an academic medical center, that in the ambulatory surgical center is something you take for granted. So having that person, that role, that champion, the expert would have been exceptionally helpful in that time. But I worked with the tools that I had, which many of us have to do. Mm-hmm. And so the operating room manager, and then of course my leader, who in this case was CEO, Chief Executive Officer, somebody who oversaw the workings of all of the facilities under the license. And so I think most change was successful, though, working with the operating room leadership, because they are so aware of the practices. And in the ASCs, a lot of the time, your OR manager or clinical manager is your circulating nurse. They're in the cases. They're not in an administrative office far away. They know the day-to-day operations. And so our first change, which was I needed to change at least one thing quickly, was to get rid of, the suspicious CHG jug. I didn't send it off for whole genome sequencing. I wish we had thought of that, but that was the first thing, is to get rid of anything that had been in the rooms, and then to quickly work with the supply chain people to facilitate ordering of single-use bottles of CHG moving forward. So that was our first step in kind of doing something that, like that low-hanging fruit that we could do right away, versus changing everybody's perspective and of course getting them to assess more appropriately for penicillin allergies. If I could just get the single-use bottles, which we don't know for sure had anything to do with it, but I knew that would be an excellent starting point and something I could do easier. And then we were just continuing to update and monitor, working with the clinical office managers to make sure, thank them for letting us know, and using that as an example to share with others the importance of letting infection prevention and leaders know if anybody suspects that anything's going wrong.
Appreciate that. Dr. Norrie, do you have any tips for us as to how to sort of point out behaviors that maybe are perhaps harmful in a way that's educational and helpful, and hopefully avoiding some of those bad feelings that can come with that?
Certainly. So Rebecca alluded to some of this, which is that she had established this kind of direct line of communication with the managers, who ultimately were the ones to report this to her. And I think mapping that out in advance of any complications or surgical site infections, it's sort of good to have a command center approach of sorts, where in a non-punitive way, there's a process to follow for one of these events that takes away blame from any one person, establishes a safety culture, which Rebecca alluded to in the beginning, and just makes it a process and not about any individual part of the chain. So I think that can be helpful. I think that another approach here is to acknowledge that we are a little bit limited in being able to pin down the exact source here without these like really sophisticated tools that honestly the vast majority of places, including hospitals, don't actually have. And so being honest about the fact that here's what I narrowed it down to, here's what I think we could help to change by replacing or doing this particular step a different way, and let's see together what the outcome of that may be. In fact, sometimes drilling down to collect specimens from the nares of the surgeons and the operating room personnel, that may be actually a little bit punitive, because you can figure out to a very sensitive degree where this is coming from. And so sometimes maybe less could be more here, and say, I'm not going to assign direct blame to any one aspect of this chain, but as long as we have a very clear chain of events and a reporting structure to quickly deal with these sorts of things in some kind of RCA process. That seems to be the approach that Rebecca took, and of course, the thing that ended up fixing the situation.
Thank you, Dr. Norrie and Rebecca, for sharing your wisdom and your experiences with us. Thank you to our audience for joining us today. I think this case really illustrates how essential relationships are between infection preventionists and the physicians and nurses that they work with. It's important, as we heard, to take the time to build trust, to offer help and advice, and to work together to find the problem and pinpoint some solutions. By creating a multidisciplinary team, IPs can better disseminate their expertise and ensure patient safety. We hope that you've learned a little more about IPC in ambulatory surgery centers and now have some resources you can turn to meet these challenges head on. Thank you.